little shorter. Well, thank you for having me here. So we're going to talk about symptomatic management of spasticity. I'm here from the University of Michigan. I am in clinical practice, and this is what I do for the primary portion of patients that I see, is just focusing on how do we manage spasticity. I have no conflicts of interest with the information that I'm presenting today. And just an overview, so I have a little bit of like the basic science of what spasticity is. Sometimes I find it's helpful to understand why it's occurring in the body, because all of our treatment options and therapies that are available really kind of stem off of why is the spasticity occurring. Looking at why spasticity occurs, what different types of medical issues are prompting or causing spasticity, what sorts of clinical effects that we see. So there are good benefits from spasticity as well as the negative, and then looking at what our treatment options are. We're going to focus on these treatment options there, are more conservative, like sort of physical therapy options, looking at what oral spasticity medications we have, injectables, intrathecal Baclofen. There's also a slew of surgical options for severe spasticity management that we'll skip today. So looking at what spasticity is, it is a form of muscle overactivity, and it occurs when there is a change in the way that the brain and spinal cord are communicating with the rest of the body. This is from the result of an upper motor neuron lesion. These occur from trauma, injury, degeneration, and the results in basically an imbalance between the way that the spinal cord and the brain can communicate with the peripheral nervous system, which is what controls then our muscle movements. There is an umbrella of terms that can be thrown out there when we talk about spasticity. I do find that some of my patients get confused when I switch between terms, so just knowing, and even in yourself, that we can say things like spasticity, clonus, rigidity, tone, stiffness, and so these are all kind of in that umbrella of terms that we would be looking at treating clinically. So looking a little bit more in depth, I'll kind of, for sake of time, rush through a little bit, but essentially to have normal coordinated muscle movements, you have signals from the spinal cord and brain that cause both upregulation or excitation as well as stopping signals, so inhibitory signals. So for example, if you were trying to bend your arm and contract it in, you need your brain and spinal cord to tell the arm for your biceps to be firing. But at the same time, you need to tell the triceps to relax so that you can have that smooth movement. So what happens in these upper motor neuron lesions or injuries is that you have a decrease in those negative signals, the ones that are blocking the opposing muscles, and then you have an increase in the ones that are causing the excitation. So then you have an overstimulation of one muscle group with a lack of ability to compensate from your other.
Hey Chelsea, I'm going to take one quick second.
Yeah,
Help you out here just a little bit. I'm going to boom this in a little closer to you so you have a little bit more movement.
Thank you.
And move this a little, make it a little easier for you. Okay, so you don't have to be so far away. Okay, hang on. I'm going to tilt this down just a little bit for you. Okay, there you go.
How's that?
Even better. A little bit
Good.
easier for you. Good for the sound guy back
Okay.
there. Get a little bit more energy.
Thank you.
There you go. And since you're looking to the right, and there you go.
Perfect.
Fantastic.
Thank you.
Thank you.
So this is a schematic of that, right? Looking at your balance between your signals that are causing the coordinated smooth movements. So you can see that you lose that descending inhibition, which is going to cause an ability for your contracting muscles to overact. This is another way to describe. We'll move on. Looking at a muscular level, because this is where a lot of our treatment therapeutics are directed towards as far as like from a therapy perspective. You have, this is your muscle. You have two groups of muscle fibers that are running parallel or at the same direction to each other. The one that's in that purple outline is what's called our capsule, and there's a spindle in there. Those fibers are really important. In particular, they receive sensory inputs and motor inputs from the brain and spinal cord. They have the ability to either make themselves more tight or looser, and depending on how tight or loose they are, that's how sensitive they are going to be to any sort of input for motor movement. So a lot of the therapeutics are looking at how do you modulate how sensitive those receptors are to kind of either downregulate or upregulate your muscle movements. And then kind of putting that schematic here into the big picture, this is what we call the reflex arc. So as you can see from the top portion there, you have a stimulus there on the finger. It's a painful stimulus. You have your signal that would travel through the arm to the spinal cord. From there, a signal will go to the brain, but a signal will also directly take itself right back to the muscle and cause an immediate reaction for removal from the stimulus. From there, the body depends on the brain to communicate with the muscle on how it's supposed to continue to react. When you have the upper motor neuron disease, you have the damage, your signals are impaired, and so you aren't getting the correct signal down to the muscle for what it's supposed to do next. So then you have this cyclical response through that arc, causing the muscles to overreact. So we can see spasticity from a variety, like I said, of diseases and injuries that affect the upper motor neurons, HSP and PLS for one, but then we're looking at some of the others that we see are spinal cord injury, multiple sclerosis, cerebral palsy, stroke, and brain injury. So looking at why we want to treat spasticity. So there's a lot of negative effects from the muscle spasticity. And these are what, as patients, as caregivers, as providers, that we're looking at and trying to determine if they exist, and then how do we manage them. So number one is the spasms can cause pain. If there's spasms that are going through different joints, it can cause altered posture. Some patients have spasticity that's running through, like their back or their core, and that over time can lead to abnormal postures there, as well as curvatures of the spine. And again, those muscle spasms can cause different forces on joints, which can lead to joint dislocation over time, whether it be like a partial or complete, which has negative impacts on all mobility moving forward from there. Skin breakdown can happen a couple of different ways. So the muscle spasticity can pull a joint, and if you lose the mobility in that joint, it can, say here in your wrist, you're flexed, it puts a lot of extra pressure there across some of the bony prominences. That extra pressure there is prone to breakdown, it's prone to trauma, and so you can have skin-related issues from that direction. The other is a lot of times muscle spasticity can cause a lot of changes in the positioning of joints. So say in the shoulder, if you're getting spasticity there, or in the elbow, you can see that angle decreases. There can be more moisture in there, so that's prone to skin breakdown, prone to yeast infections. Spasticity can impair sleep for both the patient and significant other. Cause difficulties with mobility, activities of daily living, sexual difficulties, reduced intimacy, either based on positioning or even spasticity that would maybe occur during intimate actions. And then in general, spasticity, it causes a lot of energy to be used up in the body. So when you think about the fact that you are fighting movements to make your mobility happen, it utilizes a lot more energy. So sometimes we see issues with chronic fatigue. The emotional social impact is also important to consider. For some people, it causes issues with their mood, impact on their capacity to work or to be in school. I have a patient recently who is fully employed, but requires certification and testing throughout her employment, and recently failed and had job-related issues because the testing is performed via Zoom these days, and she couldn't keep her face in the Zoom screen, so the assumption was she was cheating. So all kind of things to think about. There are really great benefits to spasticity. So from a provider aspect, I think about these things quite a bit. So if there are these good benefits available, we want to try to maximize them. The one is that spasticity causes some degree of tone in the body. This can help with the sense of stability and strength. So it can help with transfers, mobility, walking. It can help maintain muscle bulk. So in weaker muscles, if they have some degree of spasticity, it can help maintain some of the bulk and the strength of the muscle. It can lead to prevention of clots and swelling, particularly in the lower body. So the spasticity acts as a muscle compression. I tell patients almost like a pump. So it's helping to kind of pump that fluid back up through the legs, so pump the blood up towards the body and prevent it from kind of pooling, sitting, and increasing risk of clots. For some people, spasticity also helps them to understand there's something wrong with their body. So you have a baseline spasticity. If it worsens in any way, then it might be a clue to the body that something else is going on. So a little bit about why we manage spasticity. Kind of went through some of that, looking at the good and the bad, but essentially helping you to reach your rehab or your functional and mobility goals. Helping to improve levels of comfort, decreasing pain, promoting sleep, and looking at the ability to ease your cares, or if caregivers are helping assist with cares, their capacity to also help in that way. Safety. Safety is a big picture when we talk about severe spasticity, or even what we call dynamic spasticity, the kind that kind of kicks in when you want to try to move. So if you're trying to do any sort of ambulation or transfers and your spasticity kicks up and throws you over or knocks you over or runs you into a caregiver, and then we're thinking about safety issues there. And also helping to reduce the energy expenditure that the body is using to try to mobilize itself and helping give you overall increase in energy. So when I talk with patients, it's a lot about what the patient's goals are, as far as for managing their spasticity, caregiver goals, and then sort of the things that I'm seeing as well. And then looking to try to only treat what the negative consequences are. And then also thinking about what sorts of benefits your spasticity may be giving you. The big starting factor is looking at where the spasticity is located. So is it really full body, full lower body? Are we looking at just a problem at one sort of joint? So is it just at the ankle? And that can kind of help you direct what type of treatment may be best for you. And then looking at things kind of in a stepladder approach. So you want to not jump right to surgery. You want to think about how can I manage this in the most efficient way, but safest way. So looking at avoiding stimuli that may increase your spasticity, and then working up to like a stretching program, physical therapy, and then other sorts of medical options that we have. Prevention, so looking for triggers that may particularly bother you, whether it be a positioning, skin checks if you're having skin problems that can cause issues with spasticity, and looking at what triggers. So these are the most common triggers that I am seeing in clinics. So if there's pressure ulcers or if there's rashes, if you've been in one position for a prolonged period of time and your body's telling you, hey, I need to move a little bit. It's a trigger to you that something has to happen. Things as small as an ingrown toenail, a hangnail, those sorts of things can trigger spasticity. The bigger ones like infections, kidney stones, gallstones, are also triggers. Constipation is a huge one that we counsel our patients on. So it's a huge trigger, so helping patients to make sure that they have good bowel regimens. And the others, looking at other medical conditions, fatigue, as days go on, sometimes, throughout the day, if you're becoming more tired, you may find that spasticity levels are fluctuating. So start with the physical therapy options. We are pretty lucky over at U of M because we work directly with a handful of neurotherapists. So we have a clinic that utilizes them directly with a back and forth between how do we manage spasticity. A lot of these things that I'll talk about, though, have the option for you to translate them into home practice, so it doesn't necessarily always have to be done by a therapist. The number one I counsel everybody on is stretching. Stretching is going to make any sort of tight muscle looser. It's going to help with your joint range of motion. What it's doing, though, when you do stretch is it decreases, you have motor neurons that are firing to signal your muscles to move. And what it's doing is decreasing that excitability. So it's reducing its ability to respond to the signals from the brain and spinal cord that are telling it to upregulate and move more. By stretching, you can maintain the flexibility of the muscles. It also helps with joint preservation. The joints normally have some fluid around the capsule, helps them to move fluidly, painlessly, and so it helps to maintain that sort of fluid level in your joints as well. If there's contractures or really particularly difficult areas, stretching can also help treat contractures. The goals, like all of these treatments, reduce your pain, improve your range, improve your function, normalize the muscle tone. Unfortunately, with all of these physical therapy modalities, all of the results are temporary. Some last longer than others. For some patients, they tell me their stretching gives them benefit for a half hour or so. Others are finding the benefits last even up to a few hours. It's helpful to at least get this in once a day, if not multiple times per day. No research has given us data on exactly how it should be done, but some of our therapy more commonly used protocols are each muscle group that's tight gets stretched for and held for 30 seconds throughout the entire range that you need to address. And then repeating those, whether or not you repeat the hamstrings and do all your hamstrings and then your calves, or kind of running through all the muscles you need to do and then moving on to the next. There are ways that we can provide like a prolonged stretch, so this will give you results for a longer period of time. This is through wearing braces or orthotics that would perform this stretch for you. The one at the top there that looks like a boot, that's an AFO, that one there in particular is a Lennard. You can also get an AFO boot, and that will help to stretch like the back of the calf. The one on the bottom there is a hand orthotic that helps to stretch out the fingers. Patients who use these will wear them for a few hours a day or a few hours at a time, taking breaks, but that can help with more of a prolonged stretch. When you're looking at more severe spasticity and you're losing your mobility of your joint, sometimes things have to get a little bit more aggressive. And so our therapists do what's called serial casting. So they will stretch your joint, put you in an actual cast. That cast stays on for anywhere from a few days to weeks. And then they'll remove the cast, re-stretch you, and then put the cast on again. The only thing that we usually have to keep close eye on is with that, because the muscle's still spastic inside, we have to make sure it's not causing any sort of trauma to the skin. Standing frames are things some of our patients have in their homes. They have at the therapy locations. This is particularly helpful for you if you're not doing a lot of standing or weight bearing or walking. Couple of reasons why. Just standing in general helps with your posture. It straightens all of the joints out and helps you to work on posture, stretching, strengthening. The other thing, though, is actually putting your weight up and in through the heels. So if your heels can be on the ground when you're standing, that will provide a neural signal to reduce that overexcitation that's coming from the spinal cord and the brain. So like I said, not only is the posture fantastic, but it actually is sending inputs for those neural connections to try to downregulate a little bit. Strength training. This can be started through physical therapy, through personal trainers, through gyms, through yourself if you're confident in what you're doing. Concerns years back with that doing any sort of activity that would stimulate the muscle in this way would actually worsen spasticity, flare it, cause problems in the long run. Research has gone to show, though, that either spasticity stays the same with strength training or it actually gets better. Nobody was found to have worsening spasticity, but the benefits end up being quite fantastic. So for some, it's spasticity improvement. For others, we're seeing improvements in bone strength, muscle strength, and as well as a big one, increased step length. So that makes it so that the movements are a little bit quicker and more fluid. The goals are, for the most part, to be really looking at the antagonistic muscle. That's the opposite muscle of where the spasm's occurring, and strengthening that. The goals of that there is that then those opposing muscles have a better ability to kind of compensate for the muscle spasm. Some of these things, in addition to helping with the spasticity, the fluidity of your movements, the step length, the strength training is going to increase the muscle strength, improve mobility, reduce falls. It's going to lower risk of injury. And then there are great benefits to heart health, bone strength, and even some reduction in some of the different cancer risks. Heat and cold modalities are easy to do at home, but can be used with therapy as well. Basically, with the cold therapy, you are using a local cold treatment to place it on the spastic muscle. Has to usually stay on for somewhere in the realm of 20 minutes, and what it's going to do is downregulate those increased signals to reduce the spasticity. That lets your opposing muscles work a little bit easier through the spasm. Very temporary measure, though, with the cold therapy. The heat therapy lasts a little bit longer, but again, it's pretty temporary. A lot of therapy locations would use the heat therapy to go ahead and increase the flexibility of the muscle, and then do this before starting some part of like a therapy program, so whether it be a stretching program or a strengthening program. So they can employ that to help kind of maximize the benefits. Ultrasound, I included this here because technically in literature we say ultrasound is helpful, and it is. At least in our therapy location, they're not using it very much though. Essentially what it's doing is the same thing as like a heat therapy. The ultrasound technique will use ultrasound waves. It sends it to your spastic muscle. That there actually heats the muscle, increases the flexibility, reduces those excitatory inputs from the spinal cord, and then helps with the capacity of stretching. This functional electrical stimulation is one that our therapists use quite frequently. You can see the electrodes on the leg there. So it's the use of electrodes. It can be placed on either the spastic muscle or the opposing muscle. And then what it does, it will give energy impulses there to that nerve around the muscle, causing it to fire. So two different ways that it's used. If you put it on your opposing muscle, the one that maybe is a little weaker, not as spastic, what it does is to help to stimulate the muscle to fire and strengthen the muscle. If you're putting it right on the spastic muscle, what you're doing is a continuous like stimulation, almost oversensitizing it and fatiguing that muscle, so that you can kind of break through some of the spasticity and achieve more results with your therapy. So our therapist will use this on its own. There are systems that can be purchased once you're taught how to use it for home use, either through these FES. TENS is another one that's used. TENS is a little bit more common, just the way that the electrical signals are given for pain control, but will still stimulate the muscle, but can be used at home. In the therapy location, for our patients that are seeing our therapist, they'll place the electrical stimulation pads on, and then our patients will get on like an RTI bike or other form of cardiovascular activity equipment. They can stim the muscles, and then you can do the exercises in that way as well. And that sort of cardiovascular exercise is also helpful in the spasticity control. These are other modalities that are used a little bit less frequently. There can be prolonged pressure on long tendons that there can reduce the stimulation, overstimulation, and help with relaxation and stretch. This can be done kind of through the stretching program and taught through by therapists. Relaxation techniques, you can consciously try to contract your spastic muscle and then consciously relax it. And through a series of repeating that over and over, it should help with the relaxation of the muscle. And then the other two there, meditation and the calm app, are really looking at how can we get your body in an overall sense of relaxation. So it's not necessarily impacting the muscle itself, but sometimes through mood, energy level, we can allow the body to relax as well. Biofeedback is the last one. Essentially, you would train your body to respond usually to like a sound. So while training, this sound would be used and employed once the muscle started relaxing. So if you're in a period of time where there's a significant flare and a spasm, or you feel it coming on, the thought or the goal is that you use that noise, you set the noise off, and it would allow some sort of feedback through the brain and spinal cord just to automatically relax. So looking at the oral medication options, I'm focused on these. There are a lot of medications out there. These are the ones technically approved through the FDA. There's a lot of other medications that are out there that we're using second line that we get benefit from as well. Thinking about oral medication options, you want to think about these for more maybe mild or moderate cases of spasticity. They can be used in more severe cases, but you want to think about the possibility that you'd need multiple different types of therapeutic options to get control typically. And then looking at these for more of a generalized picture. So full body, full lower body, full leg. If you really are only talking about spasticity of a very local part, these would probably be effective, but I don't know if it's necessarily the first line option because of side effects. So looking at the 4 medications that we had outlined, they are Baclofen, dantrolene, which is also known as Dantrium, diazepam, which is also known as Valium, and tizanidine, which is also known as Xanaflex. They all act in very similar ways to try to reduce the excitation from the signals from the brain and spinal cord. The Baclofen, the Baclofen, the diazepam, and the tizanidine act on different chemical modulators, and then your dantrolene is working kind of right at the level of the muscle. These all have been shown to improve spasticity measures, improve your range of motion, reduce the spasticity, and stiffness. The big disadvantages with all of these medications that we consult patients on and look at is that they all can lead to sedation. They're all pretty fatiguing to different degrees, and for each patient it's very different on what their response will be. So what's typically done is you would start these medications at a low dose and then work towards titrating up. And doing it that way, rather than trying to kind of target right where you need to be, helps to minimize some of the side effects that you may feel. The side effects from oral medications come because it's an oral medication. The effects don't stay right at the spinal cord and the brain. They are effects because the medication goes to your brain. That's where the sedation comes from. The medication also goes to the stomach, and the stomach's a muscle, so it can relax your stomach. So you can have nausea and you can have vomiting. There can be acid reflux. The medication goes to the rest of the GI system, which is like your colon and small intestine, so there can be problems with constipation. For the most part, though, these medications are tolerated pretty well outside of just that sedating factor. These are some of the other alternatives that have been used in practice. There are more besides just this. Gabapentin and Lyrica are used primarily for neuropathic pain, but there are also benefits to spasticity reduction. Cyproheptadine, I don't really see actually used all that often. A bigger topic, which is probably an entire lecture on its own, is the use of recreational or medical marijuana products, which have been shown to give great results for some patients. And then Flexeril is definitely one that's been used. If the spasticity is honestly entirely related to, for you, the HSP or the PLS, it's not going to have any benefit because that spasticity is caused from the brain and the spinal cord. The Flexeril is acting directly on the muscle to relax it. So somebody who has like a strained back or a strained muscle. So not saying it wouldn't be beneficial if any of those sorts of things happened, but for the primary treatment of spasticity, it's not very effective. So looking at local injections, this is something that we talk to patients about, maybe more so to start if there's only one spot or a couple small spots that are bothering you, or if there's those couple spots that are still bothersome despite being on therapy management, despite being on oral medications. There's two different kinds of injections. The one you probably have heard of most is Botox. That's the one that's probably used the most often. It's an injection that's done directly into the muscle that's spastic itself. And then what happens, it will block the chemicals that are trying to cause the muscle spasm. So right there, right, very local. So because it's a local injection, we don't see a lot of side effects from it. But what you would potentially see is weakness, and that is not from the Botox itself. It's more so because you've dropped your spasticity and your tone, and you are actually utilizing that or needing that to help you with your mobility. Flu-like symptoms are possible. Antibody formation is the big one. It's typically only seen if the Botox is given at a less than 3-month interval. And the risk of that is if you formed the antibodies, then you would no longer get a response from the injection. So the injections have to be spaced out at least 3 months apart, but the benefit for most people is somewhere around the 6-month range anyway. The other injection is Phenol. We do use this in our clinic. It's used to target some of the bigger muscles that might be spastic that Botox may not be as effective for. The target's a little bit different. You're targeting your nerve. And because you're targeting the nerve, the biggest side effect with the Phenol is some discomfort during the injection, like a burning type pain. It's very temporary and would wear off a short period of time after the injection is completed. And what this would do is the Phenol, it's an alcohol. It will cause some destruction of the myelin around the nerve. The myelin is what helps the signal to move along the nerve. So essentially by trying to reduce that signal from moving, you're slowing the signal down and reducing that spasticity. And last that we'll talk about is intrathecal baclofen therapy. This is what I do the most with in our clinics. So moving towards intrathecal baclofen is done for our patients for a variety of reasons. Either their spasticity is not controlled with any of the other therapeutics that we've used, right? The medications, the Botox. The other reason we use it is if the side effects of the other treatment options are just too high to tolerate continuing to use them. And then I do have a few patients who just have a hard time with pills in general. They don't want to be on a lot of pills, or they find that they have difficulties with like managing when to take them. So they're often forgetting doses, and so then that's not helpful in their spasticity regimen. What the pump will do, so you can see it there, it's about the size of a hockey puck. What it will do is it will deliver a liquid form of the baclofen straight into the spinal fluid. And by going straight to the spinal fluid, you're using a much more concentrated form of the medication. You get much better results and with a significantly lower dose. And because you're also skipping the systemic effects, right? The drug is going to the spinal fluid, it's hitting the nerves of the spinal cord. You're not hitting the brain, you're not hitting the stomach, you're not hitting the intestines. You're really minimizing your side effects. With the pump itself, we can be pretty customizable to what a patient needs. So with the pumps, you can deliver a pretty continuous rate in the spinal fluid, so you have a pretty steady rate of drug. You can also flex your rates, so you can give somebody more medication during the day, less at night. You can give boluses throughout the day. There's also ways that the patient can use, if you're familiar with like a PCA, they can use it sort of like that, where they can deliver their own bolus as well. When we're thinking about, is it right to move from all of our other therapy options to the baclofen pump? There's a few considerations that you have to think about. Whether or not the indications are there, right? Did you fail the oral medications because of side effects, or it wasn't treating your symptoms, or you're having a hard time with the use of the pills? You talked with your provider about what the true goals will be of the therapy. There's a test dose that's done. Did you respond to the test dose? And are you able to come in for follow-ups? So that's a big one there. So not everybody is a candidate for the intrathecal baclofen pump because maybe they have transportation problems. Maybe there are issues with changing in caregivers, and there's a concern that there would be like a lapse of therapy. So this is the setup for how the test dose is done. It's a lumbar puncture, so that's a needle stick into the low back. So it's below the level of the spinal cord, but it gets the needle into the spinal fluid. Then you inject a small amount of the liquid baclofen into the spinal fluid. Before the injection happens, a physical therapist, occupational therapist would evaluate you, look at what the spasticity measures are like, the range of motion, the strength, and then 3 to 4 hours after the injection is done, those same therapists do a repeat evaluation to take a look at what the response was. So the idea that a test result was positive or effective would be through a series of, did the PT and OTC measures, right, that there was improvement? Did the patient find that there were measures of improvement? And were there no negative effects? So with using intrathecal baclofen, with it being so strong, there's the potential for, loss of too much tone, for weakness, causing more difficulties with your mobility, with your walking, your transfers, etc. So those are all things to look at when you're thinking about if the test that you did was a good result or a negative, or are we inconclusive and we want to repeat it again at a different time. If you've determined that intrathecal baclofen was the therapy option for you and your provider agrees as well, the device gets surgically implanted. Like I said, it's a hockey puck. The hockey puck goes into the lower abdomen, right or left side. There is a small tube that then goes through the side of your body towards the back of the spine, and then the tube is inserted into the spinal canal. And the drug is then delivered into the spinal fluid. The surgery itself is also pretty customizable because we have to think about what are the goals. Are your goals to control your tone in your lower body? Are they your abdomen and back and lower body? Are they full? Is this a patient who has spasticity from shoulders down? So the level that you put the catheter at is determined based on where the control is needed. The post-operative period of time requires a little bit of tweaking. So is either done in a clinic or in a hospital setting, depending on what your institution has to offer. But essentially it deals with a series of dose increases. So the pump is started at a very low dose for safety reasons, so we can see how you do. And then it's a series of increases in the intrathecal dose while at the same time weaning off any oral medications that you may be on. Once you get the dose finalized, it's usually fairly stable. And then the visits usually are just required to refill. The device has a reservoir where all the drug chamber, where all the drug goes. And the refills are with a needle poke, almost like a port access, straight into the device, and then it's filled, like I said, on average every 3 to 6 months. The side effects of intrathecal baclofen therapy are usually substantially less than oral medications. They're usually only there if the drug therapy is not at what we call therapeutic dose. So if the dosing is too high or there's like an immediate loss of therapy for some reason. Like I said, if it's too high, that's usually where we're seeing the side effects. And this, again, plays into the role of now the drug can be causing relaxation of your muscles elsewhere besides just like the legs and the arms, the back. So you can have issues with nausea, vomiting, acid reflux from problems with relaxation of the stomach. Relaxing the bladder can cause urinary retention or difficulties emptying your bladder. Relaxation of like the rectum or the colon can cause problems with constipation or difficulties emptying the bowels. And then you can have headaches, dizziness, sleepiness if the dose is too high. There are complications, and I want you to be aware of that, with the intrathecal baclofen therapy. There are a lot of resources in place to really mitigate all of these from happening, but it is a possibility. It's rare, but it's a possibility. So there can be issues with the device itself. There's a computer chip. It's electronic, and so electronics may fail. It's got a tube that goes from the device through the body and into the spinal canal, and so that tube has the possibility of moving, cracking, kinking. There is a potential for infection around the device, or even infection of like the surgical incision areas, causing like the surgical incision to open up. And then the other big one that there should be a million safety protocols in place for is human error. So human error is a possibility, right? Because if your provider has programmed your device incorrectly, they refilled it incorrectly, they used the wrong drug. Those are things that would be human error, but there should be system-wide policies in place to really mitigate those and make it a safe therapy. So summary, really this is to kind of give you some knowledge of what exists, what sort of step-ladder approach we're looking at on our end, and I talk with patients about, so you can kind of use this as your own tool and really, especially with the therapy sort of modalities, really implement that on your own. But summary, spasticity, it's that muscle overactivity that's from that abnormal connection or signal that's coming from the brain and the spinal cord and the upper motor neuron lesions. No cure, but what we're doing is really looking at symptoms becoming adequately managed. And treatment goals really need to take place with conversations with your providers, between you, if you have a caregiver, and your provider. What's safe, what is healthy, and what's needed. And then the range of treatment options is anything from conservative to just stretching every day, all the way up to, you know, like our most invasive surgical maneuvers. And then looking at how to adequately control. And oftentimes for most patients, they're using a couple different levels of that ladder. I think that's it. Any questions? If you want to talk loud. Yeah. Yeah. That strengthening that isn't what? Oh, yeah. So I like highly utilize my PT/OT team. There are a lot of strength training options with what we call body weight assisted or even muscle contraction assisted. So thinking about, you know, really as you're bringing an arm in, right, just resisting versus even like body weight type of exercises. A lot of our strength training options, sorry, that was just I thought a funny picture. A lot of the options that we have really do not involve actual weights. If you're able to add a little bit of resistance, therapists have a lot of what we call those resistant bands, those different color stretchy rubber bands that can be really helpful. And if, like I said, if that is even too much, just using your body to run through the movements is actually helpful as far as strengthening goes. Go ahead.
Hang on. Made you move.
Oh.
Here we go.
I was just curious, you mentioned that the pumps, you can sometimes adjust your own doses and give, because both my husband and our son have pumps.
Okay.
And we're lucky enough that the company comes to our home to fill them. And she works, she's a godsend, because otherwise we'd be driving an hour each way to get the pumps filled. So she just comes, but they have the built-in boluses when they need it the most, but it changes with seasons, and with winter you need more and all that. And you mentioned something about now they have it so they could give their own boluses.
Yeah, so the device is what we actually call is like a medication delivery device. It first was developed and used for the treatment of chronic pain. And so they used it and gave these patients like a baseline dose. The remote,
That was me.
give a
Sorry.
bolus, looks like a cell phone, honestly. They put it over their device, and it would give them a bolus. It's pre-programmed. Say the doctor said you can have 2 boluses a day on top of your base dose. So that kind of got adopted then into spasticity management. In my pump practice, I honestly don't use it at all because I find that once I've set it up, the utilization is very low for what is needed to add a bolus, that really the patients just need a fluctuation in the overall dose. To get that bolus program set up though, Medtronic would have to get involved with your provider because they have to pair a remote to it before it could even be programmed.
Okay, another question. Okay. Somebody on the aisle.
Thank you. We've had a lot of interaction with therapists and treatments for spasticity since my son was 2. He's now 18. But in the last 3 to 4 years, we've heard more about dystonia than spasticity. Can you help me to decipher the difference between those two? Practitioner, just to understand what I'm asking,
Yeah.
practitioners will bring both up and say, this is causing this is causing that. Here's a treatment for this, here's a treatment for that, and it's still muddy in my head.
It's pretty muddy, not gonna lie. It is, the line between the two is pretty muddy. The dystonia often is coming more from abnormal brain signals than spinal cord signals, and the movements look slightly different. The overall management, still, we use the same courses of management to control it. With spasticity, maybe
Right now
having
it's-
a little bit less options than dystonia. Dystonia, there are a few other oral medication options available for dystonia management. All of the spasticity management that I talked about is also pretty effective, as well as deep brain stimulation. But I would say that the response to therapeutics from a physical therapy perspective should still be pretty effective as well. Similar causes for why they're occurring, although dystonia is coming usually more from brain signals than spinal cord signals. And there are slightly different treatment options that can be focused on that may give a little bit better control.
Okay, let's do one more. We got one more? I'm gonna go way in the back. Sorry. It's their turn. Going way back here. Here you go.
In your therapy, have you used the Baclofen along with diatropine together, or one at a time?
So with our spasticity clinics, so we usually start, honestly, unless there's a contraindication, Baclofen first line. And then as we're using those medications to treat patients and we're going up on the dose, we find that the control is not, it's still not effective. We start adding on, and there are some of our patients who have very severe refractory spasticity that we honestly will have them maxed out on 3 to 4 medications, also getting Botox, Phenol. So it's not, we're not limited to using one or the other. There are a lot of times that we are using multiple different therapeutic options in these patients.
Thank you.
Mm-hmm.
Okay, guys, we got time for one more. I see that hand. There you go.
And I can answer questions later,
There we
too.
go. Yes. Here you go.
What is the difference between an oral baclofen and the baclofen used in a baclofen pump?
The drug itself is entirely identical. The intrathecal baclofen is a very concentrated liquid. And the benefits that we see with the intrathecal baclofen is that the medication is concentrated in the spinal fluid, so right onto the spinal cord and those spinal nerves, which is where the excitatory signal is upregulated. The disadvantage with the oral would be that you have those systemic effects because the medication doesn't get ingested and go straight to the spinal cord. It gets ingested and goes to the spinal cord and the kidneys and the colon and the stomach and the brain. So the drug themselves is identical. It's just looking at what are the benefits and the risk and which one do you find that you're more comfortable with. So the oral is obviously risk of the side effects. The thought that maybe you haven't been able to achieve like optimal treatment. And then the pump, obviously thinking about it as far as like it's a long-term commitment. Obviously can be reversed and removed, but while you have it, it's a long-term, marriage to your clinic and your provider for managing. It comes with, the need for surgical implantation, and it comes with the risks. It's an external electronic device that's implanted that has risks.
Okay, everybody, thank you very much.
Thank you.
Chelsea, everybody.